and good day. My name is Iván Montes. I'm a specialist in human reproductive medicine, member of INSER Bogotá, Colombia. And today we're going to talk about controlled hyperstimulation syndrome, controlled hyperstimulation treatment in poor ovarian reserve patients. This is our agenda for today. We're going to talk about introduction. I'm going to do the introduction about why this type of patients is very important for us. The definitions related, or a lot of definitions that exist surrounding the poor ovarian response, poor ovarian reserve, or ovarian insufficiency. We're going to identify the type of patients that we're going to treat and also the treatment options. Okay, so why is so important to speak about patients with poor ovarian reserve? Well, it's one of the most common causes of infertility in the world. Almost 1/3 of the patients might be related to advanced age, which is patients above 35 years old, or another cause of primary ovarian insufficiency, also known as premature ovarian failure, or poor ovarian responders, patients that exist around the world. Depending on the article or the literature that you find or that you read, you're going to find that between 5 to 20% of all our patients are related to this type of diagnosis. And the incidence is only going to increase with timing because of the social delay of women of childbearing. Although the most successful treatment option for poor ovarian responder patients is the egg donation, many, if not almost all the patients, prefer trying first with their own eggs before taking the decision of egg donation. And another important problem is the inconsistent data on the treatment options and the outcomes of those different options of treatment, making patients with poor ovarian reserve or poor ovarian response always a challenge for physicians. So there are a lot of different definitions of poor ovarian reserve, poor ovarian responders, or ovarian insufficiency related to the treatment or the type of treatment that we're going to do. And the first thing is that different standards have been developed for the definition of poor ovarian reserve. Parameters related to patient demographics, female age, ovarian reserve testing like antral follicle count, basal serum FSH levels, or serum antimullin hormone levels are also used, and the outcomes of previous IVF cycles, the results or the outcomes of previous IVF cycles, like history of cancellation, number of preovulatory follicles on the day of trigger, serum estradiol levels on day of trigger, number of oocytes retrieved, number of mature oocytes retrieved, number of good quality embryos, and daily and total gonadotropin consumption. And the thing with all this type of definition is that there's a different threshold for each criterion. And in a study related in 2011 with 47 randomized clinical trials involving women with poor ovarian reserve, 41 different definitions were used to define this group of patients, which is like a headache for us trying to define how can we say that there is a patient with poor ovarian reserve. So in 2011, the ESRE reunited and carried out the first systematic effort to define women with inadequate response to ovarian stimulation. So the Bologna criteria were created, and at least of 2 of these 3 criteria must be present to define or to classify a patient as poor responder. Advanced maternal age, above 40 years old, a previous incident of poor ovarian response, like cycles cancelled, or less than 3 oocytes with a conventional ovarian stimulation protocol, or a low ovarian reserve test, the number of follicle count that are less than 5 to 7 follicles, or anti-Müllerian hormone less than 0.5 to 1.1. Two of these three criteria are required for a poor diagnosis. In addition, 2 previous episodes of poor after maximal stimulation are sufficient to classify a patient as poor ovarian responder, even in the absence of the other criteria mentioned. This consensus definition was initially introduced with the primary objective of standardizing the definition of the poor ovarian responder patient based on oocyte quantity for use in research studies, but around the globe was used as a diagnostic criteria for defining the treatment. And the real problem here is that there is no same treatment options for patients with less than 35 years old or patients above 35 years old, with just that are included in the same definition as the Bologna criteria were defined. So the heterogeneity of the patients is so big that there was another study in 2013 using the Bologna criteria to classify the live birth rate patients in this group. And the thing is that with the same definition of the Bologna criteria, they find 8 different groups of patients. Using the criteria of above 40 years, they find another, when they combine it with one previous poor ovarian response episode or abnormal ORT, other risk factor combined with one previous poor episode or abnormal ORT, one previous POR with patients above 40 years, other risk factor or abnormal ORT combined with patients above 40 years, other risk factor, previous POR episode, or 2 previous of poor ovarian response after maximal stimulations alone or with another criteria. And they're so difficult to include the patients in this Bologna criteria. So right now we're not using the Bologna criteria to classify patients. So that's why I wanted to bring this to my presentation, is that we used to use this classification, but the thing is that it's very difficult for us to be able to treat patients with this classification. So after that, in 2016, clinicians remain without evidence guidance for therapeutic management for the POR patient, and often rely on personal experience or anecdotal facts to handle such patients. So they establish a new classification that is called Poseidon criteria. That means patient-oriented strategies encompassing the individualized oocyte number group, that proposes a new and more detailed stratifications for low patients who undergo ovarian stimulations for IVF treatment. It proposes a change in the definition of poor ovarian response from quite an heterogeneous criteria like the Bologna criteria to the concept of low prognosis group. And low prognosis seems to be ideal terminology because it allows not only to identify patients who have a reduced probability of pregnancy in ART treatment, but also to stratify the low prognosis patients into 4 distinct categories based on quantitative and qualitative parameters. In this classification, age and expected unemployment rate classifies in young or older patients. The ovarian biomarkers like antral follicle count and anti-Mullerian hormone classifies them also into adequate or poor ovarian reserve. And also, actually we have another subgroup in the adequate ovarian reserve, and is that patients that have already done a previous ovarian stimulation cycle and had less than four oocytes, or the subgroup B, 1B, where we can find at least 4 to 9 oocytes retrieved in a previous ovarian stimulation cycle. So this classification offers a possibility to improve the certification of poor ovarian patients, which might potentially improve the study design and help to fine-tune the treatment for exactly the type of patient that you might find. And if you can find a better classification, then you will have a higher successful rate in IVF treatment for each subgroup of patients. So as I told you before, obviously the best treatment option for poor ovarian responders after a few IVF failure is egg donation, whereas the live birth rate in poor ovarian reserve and in ovarian insufficiency patients range from less than 1 to 10%. The live birth rate after egg donation ranges from 50 to 70%. However, most or almost all patients with poor ovarian reserve would persist on multiple attempts to achieve the desired pregnancy using their own eggs. And we have to respect that and try to help her as much as we can. So I'm gonna divide this part of the lecture in the treatment options, which ones we use, which ones we don't, and why we use them and why we don't. And after that, I'm gonna show you a recommendation of treatment that we would like you to have and to remember and to use it when you're gonna treat a patient with poor ovarian reserve. So the first thing is the generate analogs. And Huang et al. Have recently compared the efficiency of an agonist and an antagonist protocol in 1,233 patients with diagnosis of poor ovarian response. And they have found a lower cancellation rate, 10 versus 22%, higher implantation rate, 25 versus 10%, and higher live birth rate, 27 versus 13%, in young poor patients, which were included in Poseidon group number 3, but not in older patients, which were Poseidon 4, undergoing a protocol of ovarian stimulation with agonist versus antagonist protocol. And they concluded that the agonist protocol was more effective than the antagonist protocol for young poor ovarian responders. However, other recent studies found no difference in cumulative live birth rate in poor ovarian responders patients according to the Bologna criteria, irrespective of the type of suppression with generate agonist or antagonist for those type of patients. So right now, we don't have a complete or accurate information related to the type of treatment that is better used in any of the groups of the Bologna of the Poseidon criteria. So actually, it would depend on the type of treatment or the option of embryo transfer. If you're gonna delay the embryo transfer, or if you're gonna transfer in the same cycle, then you would have to choose between the agonist or the antagonist protocol. If you don't know if you're gonna transfer or not gonna transfer, but you're not completely certain about the type of treatment that you should do in your patient, we would recommend the antagonist protocol to treat this type of patients. On the androgen, well, the androgen receptor are expressed in the theca cell, the granulosa cell, and also in the oocyte. And the expression of these receptors in follicular cells is critical for normal folliculogenesis and ovulation. Therefore, various androgens, mainly testosterone and DHEA, have been clinically tried as co-treatment before and during the ovarian stimulation treatment in patients with poor ovarian reserve, but the success was very limited and equivocal. Whereas androgens may augment the early stages of folliculogenesis, they may be detrimental in supraphysiologic concentrations on the later stages of folliculogenesis, leading to follicular arrest in the size of 2 to 9 millimeters, inhibiting the formation of a mature follicle and, well, a good follicle. Meta-analysis using testosterone as co-treatment in poor ovarian reserve patients found that adding the testosterone to the ovarian stimulation had significantly increased the number of retrieved oocytes, number of generated embryos, clinical pregnancy rate, and live birth rate in comparison to controls. But other publications have found the opposite. And the thing is that apparently the problem is the detrimental effect on later stages of folliculogenesis. So we can conclude that the androgens for this type of patients is not doesn't cause a sensational or even a very significant improvement, but it might help. And the stage where it might help is before the ovarian stimulation treatment. So a lot of articles, a lot of specialists recommend the treatment with androgens before the beginning of the treatment with the hormones or the gonadotropins during the ovarian stimulation cycle. The addition of growth hormone co-treatment to gonadotropins in ovarian hyperstimulation may upregulate the intraovarian insulin growth factor number 1, and that could augment the stimulatory effect of FSH on folliculogenesis. The growth hormone co-treatment can possibly increase the conception rate. Unfortunately, not in all poor ovarian reserve patients. DACLI examined the role of growth hormone in a prospective randomized controlled trial with 240 patients using the Bologna criteria, because this study was before the Poseidon criteria. And the thing is that the patients use the same protocol, using the agonist protocol, but in the second group, they also use growth hormone. And despite an increase in the number of retrieved oocytes, metaphase 2 oocytes, and fertilized oocytes, there was no significant difference in the live birth rate. And the second thing is that the addition of growth hormone in ovarian hyperstimulation treatment for patients is quite expensive. So you might not use them in all these patients. And some of the recommendations would include the patients that are in the group number 3 of the Poseidon criteria. There is also another problem, and that there is no one only protocol option, but there's a lot of protocol options during the treatment of hyperstimulation. There's one that says that you can use 2 to 4 units per day, each day until the oocyte retrieval. And there's another protocol that says that you can use between 16 to 24 units per cycle, doesn't matter the day that you use it. we would recommend that you use between 2 to 4 units between the day of the beginning of the ovarian stimulation until the day of the oocyte retrieval. Each day or one day you use it and one day you don't. And both of those type of treatment can be used and they work for this type of patients. With the glucocorticoids, in a few cases of poor ovarian patients, the etiology seems to be an incorrect immune recognition of ovarian self-antigens, such as an anti-FSH receptor associated with other autoimmune phenomena, or antibodies against different tissues beside the ovary. One of those examples is the Addison disease or the autoimmune thyroiditis that can sometimes the ovary doesn't respond the same way in patients with this type of diseases. So also another type of patients is the autoimmune polyglandular insufficiency, and this type of patients would have a better outcome using the glucocorticoids during the treatment. But the efficiency of treatments for immunosuppression, is unclear. It's unclear, and despite suggestions, it might be anecdotal cases, and the beneficial effects of these treatments has not been demonstrated in prospective randomized controlled trials. So actually, we don't recommend the use of glucocorticoids in all patients, but sometimes in patients that have already done a treatment before and the response wasn't good, and they might have one of those type of diseases related like autoimmune thyroiditis or Addison disease, you can use the glucocorticoids. In other type of patients, we don't recommend it. Also, there's another use for coenzyme Q10, but we can use it here to help the quality of the eggs. And whereas the causes of poor ovarian reserve or poor ovarian response are unknown in most cases, and since oxidative stress and mitochondrial dysfunction have been put forward as one of the possible pathophysiological mechanisms, the antioxidant coenzyme Q10 has been tried as a co-treatment in this type of patients, but young patients. The CoQ10 antioxidant is a lipid-soluble coenzyme that is obligatory in the inner mitochondrial membrane and enables the transport in the mitochondrial and helps the oxidative phosphorylation. Also important for the production of the ATP. And preclinical studies in animals have suggested that this can be helped as protection or helps protect the ovarian reserve. It can also be useful trying to protect from the effect of the aging of the ovary, restoring mitochondrial function and augmenting embryo cleavage and blastocyst generation. It means that it doesn't help with the number or the quantity of the eggs, but it might help for the quality of those eggs. And it might help improving the response to ovulation induction or decrease the fetal aneuploidy in these patients. Other options of treatment that have been used a lot are acupuncture, holistic medicine, and autologous platelet-rich plasma. And the effects of acupuncture on IVF outcomes are equivocal. Most poor ovarian responders patients feel anxiety and frustrations after having undergone several unsuccessful IVF cycles. In desperation, they fall back for anything that might possibly improve the outcome or an IVF treatment. A recent meta-analysis of 27 studies, including 6,116 patients, have found that although the clinical pregnancy rate of the patients who had acupuncture during IVF was significantly higher compared with controls, the live birth rate was not very different. And another subgroup analysis demonstrated that the benefit of acupuncture was more significant for women who had undergone repeated IVF cycles, possibly including patients with poor ovarian reserve who were very anxious about the treatment. The authors themselves declared that the reporting of the existing studies was poor and they had a methodological flaws. Therefore, larger studies with better methodologies are needed to validate the findings of their meta-analysis. The same feeling of anxiety and frustrations after poor ovarian reserve treatment and repeated unsuccessful IVF treatment led to couples to find holistic medicine, like acupuncture, and they had almost the same results. So, well, actually, it's difficult to recommend or not recommend it because it might help with the anxiety of the patients that are going through the IVF treatment. So they can use acupuncture as a way to release the anxiety and the frustration of the IVF treatment, but for themselves, they might not help the treatment for the outcome of live birth rate. And there's another treatment that have been used in the last year with a glimpse of a new hope for poor ovarian patients that has been suggested by two preliminary publications. In these reports, the autologous platelet-rich plasma was injected intra-ovary by transvaginal sonographic guidance before the IVF hyperstimulation treatment. And the preliminary results suggest a trend toward better implantation rate and live birth rate in those poor ovarian patients who have received the intraovarian platelet-rich plasma injections. But the thing is that we need prospective studies to start using this as a way to help our patients. So right now we're not using it for this type of treatment. So after you have made diagnosis of poor ovarian reserve or poor ovarian responder or low ovarian responder, and maybe have used a priming treatment in this patient, it is time to choose the right stimulation protocol. And I'm going to use this guidance that was done also by the ESRA, where they classified patients as low responders, normal responders, or high responders. And when they're choosing the protocol, the first thing is that you have an advantage. And this advantage is that you can choose between an antagonist protocol or a GnRH agonist protocol. The recommended dosage of gonadotropins is between 150 to 300 units per day, and always using FSH plus LH to also stimulate the production of androgens. And keep in mind that it's very necessary to do an ultrasound follow-up for any of these cases. The trigger for low responders can be done using 10,000 of HCG units or 250 micrograms of recombinant HCG, because the risk of ovarian hyperstimulation is very low. It's very low. And you can also decide to do a fresh embryo transfer or cancel the cycle, or freeze the eggs or the embryos or do a PGTA testing, a different type of treatment, and then in another cycle do a preparation of the endometrium and transfer later. Here comes the cycle cancellation. And when we cancel the cycle in low responders, well, there's another controversy related to this, because we prefer if we have at least 1 or 2 follicles not to cancel, because the response in a later cycle, it might be the same or even worse. So we recommend that you don't cancel the cycle when you have at least 1 follicle that can be retrieved. And the only reason to cancel the cycle would be that she doesn't have any response. In that case, we will recommend to cancel the cycle, and well, think about, and it would be preferable to think in egg donation for this type of patients. So which is our recommendation? For ovarian patients where you already have done a treatment, or ovarian stimulation treatment, and you have not recovered the number of eggs that you were expecting, or that you wanted, or that the patient wanted, or that you have already canceled one cycle treatment because of the low response, you can prime that patient. And the recommendation is that you can prime her with testosterone or DHES for at least 2 months before the new hyperstimulation treatment. You can also use coenzyme Q10 for at least 2 or even 3 months before the ovarian stimulation. You can use growth hormone only in special cases, and you can also use clomiphene or letrozole that can increase the response of the follicles during the ovarian hyperstimulation. This is the protocol that we recommend. First, we're going to use FSH, recombinant FSH, and you can also use LH, recombinant LH, or HMG that would bring the same result for these patients. So you start on the day that her menstrual period comes, you start the medication, both of them between 150 to 300 units in total. And you can also use the GH every day, or 1 day and 1 day and 1 not. And you can also use letrozole plus gonadotropins or clomiphene plus gonadotropins. All of them are none of them is better than the other one. The results are almost the same, but you can choose. And the results might be almost the same. And this is an antagonist protocol, so we're gonna do an ultrasound when we begin the treatment, and then we're gonna do another ultrasound between the 5th to the 6th day of treatment, where we can see the leading follicle that is around 14 millimeters. And if we can do that ultrasound, we would start the GnRH antagonist on the day that the leading follicle is above 14 millimeters, or is 14 millimeters, not before. But in case that you cannot do this ultrasound, it would be better to start the GnRH antagonist between the 5th or the 6th day in a fixed protocol. We would do another ultrasound until we have the eggs ready for extraction, and then we would do the trigger using HCG, recombinant, or normal. It doesn't matter, because the risk of having hyperstimulation is very, very low in this type of patients. So it's very controversial to do the hyperstimulation treatment for these type of patients, because now we know that the lower the number of oocytes collected, the lower the chances of pregnancy. So when we have less than 1 to 3 oocytes, the live birth rate per cycle, including all the embryo transfers, is less than 20%. And with one fresh embryo transfer, only counting that first embryo transfer, the percentage of pregnancy is less than 10%. So I know that it's very difficult for you when you have the patient in front of you and she's telling you that she wants a baby with her own eggs, to explain this, but this is the best way to make them understand that you can start with your own eggs, but in case that it doesn't work, then you can pass through the whole process and to the other side of the process, where is the egg donation, where, well, we have a 50 to 70% rate of pregnancy, which is pretty good. So I wanted to conclude with this picture of how can we help our patients with poor ovarian reserve. Well, the first step would be to identify the patient that is at risk of a future low ovarian reserve, recognizing risk factors and clinical clues during the medical consult. There is an increasing evidence that lifestyle factors such as nutrition, exercise, smoking, substance abuse, and can dramatically affect the reproductive competence of the patients, of all women actually. So when you see a patient, even a patient that is not looking for fertility, you should see those red flags that can help you identify the patient that might be at risk of having poor ovarian reserve later in her life. Patients with a volume of the ovaries that is not in the normal values, or the antral follicle count that you see is not the number that you're expecting according to the age. Her FSH level are a little bit higher than the normal to the expected age, and then the anti-Müllerian hormone is not the same as you expect at the age of the patient. You should recommend to prevent, and the way of preventing having to think in this type of patients is to preserve fertility, to preserve eggs. That would be my first recommendation for this type of patients. But, well, there's actually no way that we can prevent the damage or the decrease of quality or the quantity of the woman eggs. But we can try to compensate these patients. How we compensate these patients? Using the Poseidon criteria. You can identify in Poseidon group 1 and 2 that these type of patients are actually the ones that benefit from an increased FSH dosage, with the addition of LH during the ovarian hyperstimulation treatment to overcome the problem that is the hyposensitivity of the ovarian to the gonadotropins. Instead, there is no benefit in patients of Poseidon 3 or 4 using FSH and LH combined. So in this group, actually the problem is related more to the number of eggs than the sensitivity of the eggs to the gonadotropins. So we should try to tailor the ovarian hyperstimulation treatment to maximize the ovarian response to the stimulation and to try to have the best eggs that we can find in this type of patients. And in patients with a clear depletion of the ovarian reserve, or in the presence of recurrent IVF failures, especially after several embryo transfer, the only option left are adoption or egg donation. And the egg donation gives us the chance of an infertile patient to undergo IVF treatment using a a cohort of oocytes that have previously been produced by a young donor, and the possibilities or the chances of these patients are really, really high to have a baby. So I want to thank you. Well, I'm here. I think that you might have a lot of questions. There's a lot of questions that all the doctors that treat poor ovarian patients have. And I can help you with anything that you want. You can text me, you can write to my email, imontes@inser.com.co, or you can call me if you want. I can give you my phone number, or you can text me via WhatsApp if you have the patient in front of you and you don't know what to do with that type of patient. I can help you with it. Okay? Thank you and have a good day.